Hi, it's Barry Z from the Barry Z Show, talking to the man who saved my life, Dr. Max Kreditor. I'm giving you credit for saving my life, you know.
Thank you, Barry. Thank you. I
Wow.
don't take it, but I was not the only one who was involved in your care. But
But you have now made me healthy and well, and it's been 5 years since I went for my cancer treatment, right?
I think so. Yeah. So you, as you remember, you had surgery, and then we gave you some chemotherapy after surgery. It's been 5 years, and you're cancer-free, and knock on wood, it will continue this way.
And it was for colon cancer.
You had stage 2 colon cancer, but
What is stage 2 colon cancer? I know they said the cancer was the size of a grapefruit. It almost killed me. I was passing out. I had no blood flowing to all the body parts, and you saved my life after the surgery.
So I didn't save your life. You were operated on initially by
Dr. Martz.
Dr. Martz, who's an excellent surgeon, so your cancer was removed. Actually, what's interesting is the size of the cancer does not matter in colon cancer.
Really?
So, yeah, really. So what matters is how deep does the cancer penetrate through the wall of the bowel. Okay, so in your situation, your cancer penetrated through the entire wall of the bowel. So we call it T3.
T3.
T stands for tumor. That's where the tumor was. Tumor penetrated through the entire wall of the bowel. But luckily, you did not have any lymph node involvement. So none of the lymph nodes that were removed by Dr. Martz contained cancer. So that's what makes it stage 2.
But why was it the size of a grapefruit? It could have killed me.
Well, that's why it's very important for any person over age 50 to get a screening colonoscopy to make sure that it doesn't get to the size of the grapefruit, that it doesn't go to T3 or T2 disease, that it is caught at the stage of a polyp. Okay, so polyp, a colonic polyp, is a pre-malignant condition. Pre-malignant means it can transform into cancer. And it's been said that it takes about 10 years for a polyp, a pre-malignant condition, to transform into a cancer. And what makes cancer a cancer is its ability to metastasize. So these cancer cells can break off and go live in the lung, in the liver, in the bone, everywhere. And at that point, the cancer is incurable. So it is much better for the patient and also for the doctor to find your cancer at an earlier stage where it's much more manageable.
Now, if I came into the gastro guy, right?
Sure.
The gastroenterologist, I forgot his name,
Yep.
Brett Hauser?
I think it was Dr. Brett Holtz.
Brett Holtz. Sorry, Dr. Brett Holtz. It was you, Dr. Brett Holtz, right? At Beth Israel Hospital, who saved my life also. Or at the beginning of this stage of cancer, you know, he got into this thing early enough to recommend you to complete my survival.
Well, actually, so Barry, you bring up a very good point. So it's not just one person who takes care of a cancer patient. So it's a team of people. So first, a colon cancer needs to be diagnosed. So Dr. Brett Holtz, a very capable gastroenterologist, did a colonoscopy, found the tumor, and took a bite of that mass. So the specimen went to a pathologist.
This is a biopsy, right?
This is called a biopsy, correct. So a pathologist is a type of doctor that looks at cells under microscope. And the pathologist determined that, in fact, it was cancer. So once we determined that it's a cancer, so cancer has to be removed. The best chemotherapy for cancer is formalin. Okay, is a solution that we put all our specimens in, okay, when we submit them to the pathologist. So surgery is really the best cure for cancer. So your cancer was removed, and because you were at risk for recurrent disease, meaning that there was some risk for your cancer to come back, even though you were stage 2, not stage 3, which is standard. We gave you chemotherapy.
It got to stage 2. I let it get to stage 2 because I didn't go for a colonoscopy and have this explored or found out about before, it reached stage 2. I was chicken. I was afraid to go for a colonoscopy, even though it runs in my family, colon cancer. I should have gone in, 5 years ago, 10 years ago, and maybe I would have not have to gone through the surgery and wouldn't have had stage 2 colon cancer.
Yeah, you actually bring up a very good point, Barry. Colonoscopy is considered a standard procedure that prevents colon cancer. How does it prevent colon cancer? Because it identifies polyps before they turn into cancer. Mm-hmm. Okay? So it's a colon cancer preventative procedure. Every doctor knows about it. Every doctor knows that everyone over age 50 should get a colonoscopy.
I have to cut you off quickly. I'm sorry about that. But I sat in this waiting room or your chemotherapy room. What do you call it?
Infusion room.
Infusion room. Okay, I was in this infusion room getting infused with chemo, right? Correct. To save my life. And there was a 21 or 22-year-old kid in this room saying he had colon cancer. So why is it only for people 50 and over?
Because cancer in general is much more common in people over 50, in older people. Okay, so I know the patient you're talking about, this young woman. She is still alive, doing very well. But
how did she get it at the age of 21?
It's rare, but it happens. I mean, it does happen. A few years ago, I had a patient who was 26 who had suffered from ulcerative colitis for about 10 years and was kind of neglected. So
he was a male, right?
He was a male, yeah.
I think I met him too.
No, I don't think you met him. He was. It was kind of. I think it was before your time. So he presented with advanced cancer. It was removed. He had a total colectomy, so removal of all of his colon. And by the time he got to me, he had liver full of cancer. So 26-year-old boy, really.
Is he dead?
Well, what can I say? It's a really sad case, actually. It's a very, very sad case. And
he passed on then, huh?
He passed on, and but I do remember him, and I think about him often. About this boy, he responded very well to chemotherapy, and he did very well for a period of time, for about 2.5, 3 years. He was doing awesome, and then at some point he started getting worse, and we tried one thing, we tried another thing, and so eventually none of the stuff worked, and his liver was again full of cancer, and we put drains in, and every doctor in the hospital saw him, and he really didn't want to give up, kept on going, but unfortunately, he died in hospice.
Oh, I'm sorry to hear that. May he rest in peace. But that goes back to something that I really wanted to explore with you, is the fact that is genealogy or heredity, the genetics, the major factor in this in terms of it causing people to have colon cancer?
Yeah, so there are definitely some well-known genetic factors. So there's something called the Lynch syndrome, so where cancer runs in families. There's familial adiposis coli syndrome, so that also runs in families. So the red flags for that is cancer at a young age, less than 50. So whenever I see someone who's young for us means less than 50. We usually test them for these conditions. It's a blood test. So these abnormal genes are present in every cell of the body.
So it is possible for someone to get colon cancer even before they're 50.
Sure. Right. So the red flag would be, oh, I have my mother had colon cancer when she was 30. My cousin had colon cancer when he was, 35. So my aunt had uterine cancer when she was young too. So whenever we see that's when, and I have colon cancer and I'm like 40. So
You?
no. So a presentation. That's a presentation of a patient, right? So when we see that, that's when we start suspecting very strongly that this person might have a genetic predisposition. But besides genetic predispositions, so for example, this young person who died of colon cancer, he had ulcerative colitis that also predisposes you to colon cancer. So
And he was 26.
and he was 26, but he had it for 10 years before. So
Did you see him for 10 years?
no, I only met him after his surgery. So he had his surgery at Mount Sinai, and he came to me for consideration of what to do next. Chemotherapy, adjuvant chemotherapy, he was referred to, but unfortunately, we did the scan, and so he was much sicker than we thought he had been.
In a case like this, there's nothing you can do to counteract this. I mean, you come from a family that has a history of colon cancer, like I do, okay? So I should have known better and gotten a colonoscopy at the age of, say, maybe 40, right?
Well, the rule of thumb is to get a colonoscopy. Let's say if you have strong family history.
My father died from it. My uncle died from it.
Yeah, so it would be, so not everyone who has colon cancer with family history is a carrier of these genetic abnormalities. Not everyone.
Really?
Yes.
So it can skip.
Well, maybe they're predisposed to colon cancer by a gene other than what we're testing for.
Wow.
Yeah, so maybe there are some genes that are still unknown.
So maybe the ideal age to test for colon cancer is 20 or 21. No?
Well, I think 50 for sporadic colon cancer, meaning population-wise, I think 50 is a very reasonable number. But if you have strong family history and you are negative for Lynch syndrome and the polyposis syndrome, then...
What are those two syndromes again?
So those are syndromes where you are missing a gene that identifies colon cancer and kills it before it becomes cancer. So yeah, so these patients have a these people, carriers of these mutations, they have a very high chance of having colon cancer. So they should be screened earlier.
Before the age of 50, of course.
Yeah, before age 50. I think that the guidelines, I have to look up at those guidelines, but I think the guidelines are somewhere around 30, 35. That's when they start.
Wow.
For colon cancer. Yeah, and they're also at higher risk for other cancers. So stomach cancer and cholangiocarcinoma, so a cancer of the bile duct. And uterine cancer. So, and we're not really sure what to do about how to screen for those.
Can you determine it in a blood test?
Not really. By the time you have blood test abnormalities, it's usually too late. So for colon cancer, you would screen with colonoscopies. For stomach cancer, you would screen with upper endoscopies. And
what about rectal cancer?
Well, rectum is part of colon. So colonoscopy or sigmoidoscopy is good enough. Is good enough, right? But to come back to your question, what should I do? I have family history of colon cancer, but I don't have, how should I be screened for colon cancer? And the rule of thumb that we use, such persons should get a colonoscopy probably 10 years before their youngest relative was diagnosed with colon cancer. So if your aunt was diagnosed with colon cancer at age 45, or your mother diagnosed with colon cancer at age 45, right, you should probably get a colonoscopy at age 35.
Wow. So Dr. Max Kreditor, or Maxim Kreditor, because you're to the maximum in terms of saving people's lives, you're called a oncologist and a hematologist. Can you explain those two terms to me?
So a hematologist is a blood specialist. So I see patients who have blood abnormalities, and sometimes these blood abnormalities are due to cancer. Sometimes they're due to other disorders, and hematologists try to figure out what these blood abnormalities are due to, and once we make the diagnosis, we recommend treatment according to what the diagnosis is. So that's what hematologists do. Oncologists treat cancer. So we're part of. So I'm a medical oncologist. There are other types of oncologists. There are radiation oncologists. They give radiation, and there are surgical oncologists. They perform surgeries, cancer surgeries. So these three specialties take care of the totality of the cancer patient.
What is your specialty again? What specialties again?
So it's medical oncology. So it's really so we give chemotherapy. We don't do surgeries. We don't do radiation. So we give chemotherapy. And hematology is figuring out abnormalities on the blood test.
You came from Russia originally, didn't you?
I came from, from Russia, from the Soviet Union Republic of Latvia.
You came from Russia with love?
With a bunch of love, yeah.
And why did you choose this profession? Why did you want to save lives this way?
Well, I always wanted to be a doctor, and I always wanted to be the kind of doctor who deals with serious illnesses. So,
were you a doctor in Russia?
No, but I did start medical school in Russia, and then my family and I decided to leave. So yeah, but my father's a doctor, and I grew up with a bunch of doctors.
What kind of doctor is he?
He's a psychiatrist. Yeah. So I was throughout my life I was exposed to doctors, and my father would take me to his hospital when we were short on babysitters and when the school was out. So I would sit in his office and listen to him speak with patients.
In Moscow?
That was in Riga, in the capital of Latvia. So right. So so I grew up with that, and so throughout my life I kind of thought of myself as something that's going to happen eventually. Eventually I was going to be a doctor. So one day I became a doctor, and I kind of thought that doctors are take care of patients. So we don't take care of patients who are not who are well. We take care of patients who are sick, who need help. So, and these are exactly the kinds of patients I like to take care of. And what is more serious than cancer?
You were surrounded by people like this, by patients, quote unquote, right? All of your life, seeing as your father is a doctor, right?
Yeah, patients and doctors. I grew up in medical profession. So my father would, when I did not go to the hospital with him, he would come home and he would tell my mother about patients he saw in the hospital, and what was interesting about them, and what kind of treatment he recommended, and how they got better or did not get better, and what was sad about their situation. And so, yeah.
You are a gift from God. That's what you are. You are a gift from God in every sense of the word by saving my life and saving everyone else's. My friend Nancy, my friend Joel now, everyone. I mean, you're incredible. How do you feel about saving someone's life? Is this the reason you became a doctor or an oncologist?
So I just to be clear, I don't take credit for saving your life, okay?
But your name's Kreditor. You should take credit.
Okay, all right. It's a job. It's work that I do. So
you have a heart of gold. You really care about your patients. You really care, and follow up with them. And your staff is the most incredible staff in the world. They really care about a life and keeping it going.
Thank you, Barry. Thank you. That really means a lot. Thanks so much.
I could cry if I talk any further because, I feel you've saved my life or helped save it with the other doctors, and you care about me living a long, happy, healthy life. I feel, the hope and the reason to go on because of you, because I know I'll be okay now because you're treating it. You've treated my colon cancer.
Barry, the best kind of doctor is the doctor you don't need. So I'm very happy that you don't need me anymore.
But I love you. I mean,
I love you too.
you're an incredible man.
I love you too. Well, thank you so much.
Care. I mean, I felt when I came in here comfortable, which most people don't feel when they come into a doctor's waiting room for whatever the illness is that they came in here for, especially oncology, which is the treatment of cancer, okay, which is like really on the edge anyway, because, you know, as you just mentioned before, people can die very easily, and you go through it with them, and you hold their hand, and you try to make them better in every way you can. You have all the latest techniques and medicines and education. So, I mean, I don't know what could I say other than you're a gift from God.
Well, we try to stay current, and we have only one rule: we do the right thing. So, and it's a very easy rule to live by. So we do the right thing.
You do the right thing in the sense that this is more than just a money thing for you. I know that, okay? You save lives. So it's more than the money, right? I mean, which you can do well in this profession as far as earning a living goes, right?
Yeah, I mean, I live comfortable. It's no problem. So.
But how do you feel about saving a life? I mean, when you saved my life or saved Nancy's life or will save Joel's life or everyone else that is your patient, how do you feel about that?
So I will tell you how I feel about saving a life. Okay, so your life, I will say it again, I did not save. Okay, so I did.
You helped?
Okay, so I did what any guy would do. Okay, any other guy would give you chemotherapy, would be part of your team, and would be happy to take care of you. Okay, but let me give you an example. Okay, I'll give you two examples of lives that I thought I saved. Okay, so you ready for this? So here's one example. So when I was in training at NYU, a man from Pakistan, an illegal immigrant, came to New York because he was diagnosed with lung cancer in Pakistan. He received treatment for lung cancer in Pakistan. And so he got chemotherapy and radiation for lung cancer, and the doctors there did not think that cancer could be removed, and he came to us. You know, can you please remove my cancer? So prior to that, he was
recommended to you, right?
No. He had no money. He was an illegal immigrant, you know. So, but because of the laws at that time, you know, you couldn't refuse to take care of him, and
something you would have done anyway, knowing you.
Thank you. That's, you know, in Bellevue, you see 100 patients, you see one patient, you still get the same amount of money, so it didn't really matter. But I like taking care of patients in general. So
saving lives.
Well, thank you. So, and that's
good karma, you know.
Okay, so that's why we took care of this person. Okay, so I took his history and you know, we scanned them, we did everything that needed to be done, yada yada yada. So I presented him to you know, we call it the tumor board. That's when you know, so you discuss it with other doctors, what should be done. So is this guy resectable, not resectable? So eventually we decided that we should probably take out his tumor. You know, we should at least try to take it out. So I arranged for him to see a lung surgeon. So the lung surgeon agreed. He was a young person. He was 30 years old, by the way. Yeah. So, and so he went in and he removed everything, and to our surprise, it was not lung cancer. It was Hodgkin's lymphoma. So,
what's that?
So Hodgkin's lymphoma is curable in about 90 to 95% of cases. Okay,
it's a blood cancer?
It's a cancer of the lymph nodes.
I see.
Okay, so we had this stuff removed. Okay, so he had no disease anymore. We gave him some more chemotherapy against Hodgkin's lymphoma, and the man was saved.
Oh, wow.
Okay, so a guy like this, okay, so a person like this, because I took interest in him.
30 years of age, you just said.
Yes, and because I pushed his treatment through the red tape of Bellevue Hospital, So a guy like this, so I consider that I saved his life. Okay.
So you did save this man's life.
So right, so I was not the only one, okay, but I was the main doctor who was pushing for this procedure, and this procedure got done. I mean, if it hadn't been done, everyone would think. And by the way, I forgot to mention, prior to coming to Bellevue, he went to another New York hospital where they did a biopsy and they confirmed the diagnosis of lung cancer. So it was a wrong diagnosis,
God.
right? So. So I was not the only one. So he had a whole bunch of doctors. So he also had American taxpayers who paid for the treatment.
That's okay. We saved a life.
Well, this is not. We're not going to discuss that during this
not.
interview. But the bottom line is that. So something like that I consider a life saved. Okay. So that would be one example, and another example of a very interesting patient actually that we treated. So about 2 years ago, this lady came to me, and she had many malignant nodules on her chest wall that were bleeding. And in fact, she was losing blood. Okay, so these nodules were due to melanoma that came back 10 years or about 10 years.
That's a cancer, melanoma. So what is melanoma?
So melanoma is a very deadly form of skin cancer. It is resistant to chemotherapy. The prognosis for melanoma up until a couple of years ago was very, very poor. On average, people would live 6 to 9 months, no more than that. Okay, so there was a very small proportion of people who could be saved with immunotherapy in the form of high-dose interleukin-2, but very, very few, maybe less than 5%.
Is it again from heredity?
Well, yeah, so some of it is hereditary, so because patients, inherit bad genes, but a lot of it is due to sun exposure.
Really?
Yes.
That's what I wanted you to say.
Right. So...
we all have to look beautiful for the sun, right? So you're telling me this patient developed melanoma. Was it because of the sun or her being a sun worshiper?
Nah, she was not a sun worshiper. She was a hard-working woman, like a regular person. She had 2 kids. She was 42. And
it ran in the family?
Not really, no. She was the first one with melanoma in her family. So she had melanoma resected about 10 years ago. Okay, she received some therapy for it in the form of interferon, and so now it came back with vengeance.
And you got it.
So
and erased it or shrunk it, and now she's okay.
So because of advances that were made in the field of immunotherapy for cancer, we treated her with a new drug, relatively new drug called Yervoy, okay, or ipilimumab, and so we gave her 4 infusions of this drug. She had a very nice response, not a complete response, but she had a very nice response. So
she's still alive, I hope.
So, but she also harbored a genetic abnormality inside her cancer cells in the form of BRAF mutation. So, and following completion of Yervoy, we then put her on these small molecule inhibitors. So the cancer shrunk a little more. So, and for about maybe 6 to 9 months, she did very, very well. And then we decided, in consultation with her, we decided to have it removed and to cover it with a skin graft. So we removed this entire chest wall area that was involved with melanoma, and we put a skin graft on top of it. And to our surprise, there were no viable tumors
Oh, thank God.
in the stuff that we removed. So immunotherapy killed all those tumors.
She's okay.
So it's been 2 years, and she is doing great. The only thing that she needs to do is quit smoking.
Your occupation is the treatment of cancer, right?
That's correct.
Okay.
That's my occupation.
Okay. Do you get involved in surgery too?
No, I don't get involved with surgery. You don't want me anywhere near the operating room.
You have the nicest touch, the warmest smile, the biggest heart, and people feel comfortable going to you, whereas usually people are afraid of going to doctors.
Well, thank you so much. It's surgery is not my specialty. So there are very many capable surgeons that I work with. So I let them do the work. I mean, I know what they do in the operating room. I know the types of procedures that they do, and so we discuss them together in conferences.
So you just do treatment of cancer.
So once cancer, so I see surgeons. They see patients episodically. Okay, so for example, like if a procedure needs to be done, they would remove a colon, they would remove a pancreas, remove a breast lump, but they don't engage in longitudinal relationship with patients, usually. There are exceptions, but usually they do not. So it is job of medical oncologists to follow patients long term. So I know what happens to them when they're diagnosed with cancer, when they go through surgery, and I also know what happens to them after surgery, and I keep following them. So some people may disagree, but I think medical oncologists know what's going to happen better than the surgeons, but it doesn't mean that the surgeon's completely clueless and they have no idea what's going to happen.
After my surgery for the colon cancer, you stepped in and you gave me 6 months worth of oncology, right? Or cancer treatment?
Chemotherapy,
okay. And you saved my life, or continued to save my life. So the cancer didn't come back, is that correct?
The cancer did not come back. You are cancer free, right?
Okay. And in order to stay that way, I still should see you on a 6-month basis, right?
Or 6 months, once a year.
And get a blood test.
Yeah, get a blood test, get a physical, so, we look for lumps, and you tell me how you're feeling, whether you're feeling well or not. So, the purpose of the visit is to see whether or not your cancer has come back, okay? And we determine that by talking to you, by listening to your complaints, and you are not shy about them? No.
But you eradicated all of the cancer. I'm cancer-free.
Right. So I have to, when I see you, I have to decide whether or not your complaints are due to are suspicious for cancer.
Because it runs in my family, right?
No. Because you had cancer before.
I see.
Yeah, so your cancer may come back theoretically, in the liver, anywhere, So, and I have to decide whether the stuff that you're complaining about is suspicious for cancer recurrence.
That's why I need this maintenance.
That's why you need to come back and see me, right?
What kind of treatment did you give me? It worked. But I was cancer-free when I had the surgery. That's what I thought. But you do the follow-up, right?
Right. So that's actually a very good point that you're bringing up. So like I said earlier, the best treatment for cancer is surgery. So a solid tumor, vast majority, you cannot cure without surgery. So surgery is a necessary component of a curative approach in most solid tumors. Okay, so your colon cancer was removed. However, any cancer can come back by definition. Okay, and some patients have.
Is it because the cancer can hide in cells within the body?
Yeah, right. So it can spread to the lymph nodes, it can spread to the liver, lung, etc., and it could be below the limits of resolution of our scans. We just don't see them, But there could be a few cells that are scattered all over the place, and at some point, years later, they may wake up.
God forbid. What did you give me as far as the treatment goes?
So you had some chance of that happening, and we gave you chemotherapy to kill those, the cells that could have potentially seeded your organs.
And it was infused through this port you told me to put in.
Yeah. So we gave you standard chemotherapy for colon cancer. That's called FOLFOX. That's a standard regimen. So as you remember, you came in on day one. I don't know if it was Monday or Tuesday or whatever. So let's say you came back on Monday. We infused you with some chemotherapy, and then we put you on the pump, right? Remember?
Yes.
So, and you were on the pump for 2 days, and then you came back, and, we flushed your port, and we removed the pump.
But I saw you for a total of 6 months.
So we gave it to you every 2 weeks for 6 months, so a total of 12 cycles. So it's a very long treatment.
But it has to be that long.
Well, that's how it was studied. Okay, so a standard is 6 months of therapy, or 12 cycles. We are questioning whether 12 cycles is really necessary. So now there's a trial that is comparing 3 months to 6 months, to see maybe we can shorten the duration of chemotherapy. So there is a clinical trial that's looking at shorter duration of chemo.
What did you use on me what did you use on me particularly in terms of the drugs that you gave me?
The drugs, okay, so we gave you 5-fluorouracil. We gave you leucovorin. Leucovorin is
that, yeah.
You remember that? Okay, so that's a vitamin that makes 5-FU to stay inside the cancer cell. And and we gave you a drug called oxaliplan, which is a platinum compound.
And it saved my life, or got rid of any kind of notation or connotation of any kind of cancer cells.
So we reduced the chances of your cancer coming back. So that's how
Even though the surgeon removed all the cancerous cells.
Right. So, but there's a possibility that cancer could have seeded, other organs. Right. So, and you can remove all those cells, right? I mean, you could only remove the lump. So he removed the lump, and we treated your whole body with, with something intravenous that went everywhere.
Amazing. So you saved my life too.
So we reduced the chances of cancer coming back. Yes. Amazing. Yes.
How do you know about all these new drugs to give your patients to save their life?
Well, I go to medical meetings, I read journals, I'm on Twitter, so I send, I get emails, so you stay current, it's part of being a doctor, so that you discuss it with colleagues, you go to conferences, so, it's, that's what we do.
So you know what drugs to give people for their specific form of cancer.
Right. So exactly. Right. So that's a very important distinction. Right. So you have to figure out, what the patient has, what stage they're in, what is their situation, and where they are in life in general. Today, for example, I saw a guy with prostate cancer who is interested in partial treatment of his prostate cancer. Okay, so he wants to remove or radiate not the whole prostate, but the piece of the prostate that's involved with cancer. That's what he wants to do. And following that, he wants to receive immunotherapy. So that was his question. So he came to me and he asked me whether or not this would be reasonable to do. Okay, so so that's by no means standard therapy. Okay, so it's not standard at all. But he told me his life story, and you know, I mean, I'm not saying I'm going to say yes to him, but at least I would consider it. I would consider. So, and that's what we decided to do. We're going to consider it, and I will also set him up with an immunotherapy expert in prostate cancer. So to see whether or not this would be a reasonable approach. I don't think it would be a reasonable approach, and I told him that. But he is not. He's the kind of guy who's not taking no for an answer. So he, you know, so he's going to go see someone else, you know, for this kind of consultation.
I think the audience out there, and me in particular, don't understand what the different stages of cancer is. You have stage 1, stage 2, I had stage 2, you have 3 and 4, and then you're dead, right?
So I think it's really for doctors, you know, the staging. So I think an average patient should think the way we think of cancer, the way I think of cancer when I see a patient for the first time, is I try to decide, is this patient curable or not? Can I cure this patient of cancer such that, you know, this patient will live, you know, 5 years, 10 years from now?
How do you make that determination?
Right. So, so in your situation, you know, when a cancer is at a localized stage, you know, just one lump somewhere, you know, we take it out and we give adjuvant chemotherapy. But so that's one situation. Another situation is where you have a lump in the colon, but also you have a lump in the liver, lump in the middle of the chest, and a bunch of nodules in the lungs. So, and you biopsy one of those lung nodules and you find that it's cancer. So that means that you have colon cancer that is everywhere. So, and that's the situation where, you know, the cancer is not curable. And the goals and discussions become different.
And what are the treatments? Does it go by what stage of cancer you're in as far as the treatments go?
So the treatment is different for different patients. So different for different cancers.
What about stages of cancer? Are there different treatments for different stages?
There are different treatments for different stages, and modalities are different. What we can do is different. The goals of treatment are different. Every patient is unique in some way. You know, we have some roadmaps, but everyone is truly different.
Is there one cancer drug that can cure stages 1, 2, 3, and 4?
No, there isn't.
No.
There isn't. So,
what drugs are commonly used to treat cancer?
so there, you know, so the list is from here to New Jersey. So we have many drugs that are helpful in treatment of cancer. So, but
You don't determine what drug to use on these patients by what number cancer they have. I had cancer 2, or cancer number 2, okay?
stage 2.
Stage 2, okay. So does it go by the stages in terms of what drugs you use?
Are you talking about colon cancer in particular, or any kind of cancer?
You treat every kind of cancer, right?
Almost, yes. Some cancers I don't treat, but almost every kind of cancer, yeah. No.
Does it go by stages in terms of the medicine you use?
No, it doesn't. It doesn't. No, it doesn't.
So how does it go then in terms of...
So the drugs that are active in melanoma, for example, are not active in prostate cancer. So you have stage 4 melanoma, you have stage 4 prostate cancer, you use different drugs. So the drugs that are active in breast cancer are different from drugs that are active in colon cancer. So
there's a specific drug for each type of cancer.
That's why it's very important to understand what it is that you're dealing with, and what are the goals of care. What are you trying to accomplish with this treatment?
You mean be it bladder cancer, be it colon cancer, right?
Exactly. So there are organ preservation issues. So some patients are, like, for example, I saw a lady, she was 97, you know. Yeah.
Wow.
So she was sent because of some blood abnormality. So what can we do for her? So somebody who's 97 with a blood problem, I think I'm going to be slightly less aggressive than somebody who's 27 with a blood problem.
Is it because the treatment can kill them quicker?
It's because of what we call competing morbidities. So if somebody has somebody's very frail, has very out of control diabetes, bedbound, demented, so they're gonna die of these conditions before they'll ever die of cancer.
I see. So it has to go by age also.
It has to go by goals of care.
Goals of care.
Goals of care.
What's that?
Right. So somebody who's 27 with colon cancer, you want to cure him. Somebody who is like you, I forgot how old you are, but like a young person like yourself, we want to cure.
I see. Okay.
Yeah.
So you definitely deal with life and death situations here.
Well, that's our business. That's our doctor business. Wow. Yep. Right.
Unbelievable.
Yeah.
In terms of also medication, marijuana seems to be something that people use in cancer treatment. Why?
Even outside of cancer treatment.
Yeah, but why? And it's not legal here in New York. They just, I think, legalized medical marijuana here in New York.
Yes, I heard that, yes.
So it's not $100 a pill, right?
I don't know. I heard from a colleague that there's a training that providers, can obtain, to prescribe medical marijuana.
Does this actually fight cancer, or is this just a calmative or something that soothes the person or stimulates the appetite to help make them better?
So I'm by no means an expert on marijuana.
I was going to give you a joint right now.
Right, for better or for worse. But I think from what I've read, it's more about symptom management. And from what I understand, there's very little evidence that marijuana has anti-cancer effects. Okay, so with regards to symptom management, I can manage most symptoms of cancer without marijuana.
But it does help. But marijuana does help stimulate the appetite, so the patient eats.
Sure, absolutely. But we also have a drug called Marinol, which is generic now. You can take a couple of pills, and and you get the munchies.
Really?
Yeah.
Is that marijuana based?
Yes, it is. But some patients don't like it. Some patients kind of get stoned.
Really?
Yeah, and they don't like it.
In terms of reaction to your treatment, I know that I got high on some of the chemicals that you gave me. But I didn't lose my hair. So, I mean, what is the reaction to people who usually have, colon cancer or any kind of cancer and have these anti-cancerous drugs?
So, there's something called chemo brain, so while on chemotherapy, it's been, recognized by now that you do develop some degree of cognitive dysfunction,
Get high.
Well, you kind of like slow down, and you're not as sharp as you used to be. So right now, you're back to normal.
Oh, me?
Yeah.
I am, right.
Normal as you'll ever be,
Right, exactly.
Right.
But what about me? Thank God not losing my hair, whereas other patients do. I mean, there are after effects from this chemo stuff.
Yeah, so if you remember, your hair did get a little thinner, okay?
More thinner than I have now?
I don't remember exactly, but usually with your type of chemotherapy, your hair, so with Folfox...
Folfox?
Folfox.
What's that? Oh, that's the medical treatment.
So that's the cocktail that we use. So, fluorouracil, oxaliplatin, leucovorin. So
that's infused to me.
Right. So your hair does become a little thinner, okay, but you don't lose it all.
Losing your hair is one of the results of getting chemo?
Yes, it's some chemotherapies result in hair loss. Some do not. Okay.
What are the other results of chemo?
So some people, for example, for some people, this is a very important issue. Not everyone, but for some people really don't want to lose their hair, and they would rather receive suboptimal treatment than lose their hair. Yeah.
What does that mean?
Well, I had I saw a young lady, for example. She had a specific kind of cancer, so she did not want to get chemotherapy because she didn't want to. She was part of Hasidic community, and she wasn't married, so she didn't want her community to know that she was going through cancer because if they found out that she had cancer, she would never get married. So that was a very strong consideration for not receiving chemotherapy.
Wow.
So we ended up giving her a drug that was not associated with hair loss, okay, but was not as active. I thought that it was acceptable based on a small study out of Finland that was done. That
did it work?
Well, she's cancer free still. So it was adjuvant treatment for HER2 positive breast cancer. So we gave her, instead of the usual treatment, we gave her something that was navabine based. So with navabine and Herceptin, but her cancer was kind of small too. So it wasn't. I didn't think that I was doing a great disservice to her by complying with her wishes.
Wow. You're telling me now that
I'm telling you that everyone is different.
how many kinds of cancers are there? How many kinds of cures? And does it happen, to people, if they don't, like me, get checked out, or checked up, early enough to save their lives?
So there are many different types of cancer, and there are many different types of modalities that we...
That's the biggest killer of people, right? Cancer.
Well, it's cancer and heart disease. Right. So those
Number
are...
one.
Yeah, I think, number one. Number two, a cancer and heart disease. So, right. So that's what people usually die from. Yeah.
And how many cures are there, or how many drugs do you know of, and how do you stay on top of knowing what drugs there are to treat these people?
Well, you study, you learn, you go to conferences, and you stay current, you read journals, but you also learn a lot from your patients. So somebody comes in and they tell you, look, I have this, and that, so what can you do? And if the answer is not readily apparent, I tell them I'll think about it. So, and quietly, I have my gin and tonic, and I think about it. I look it up online, on the internet. I go to Mount Sinai has a really awesome online library, so it's a great resource for me, and I think about what is the best thing for them, and then I tell them what I decided, and if
You only meet with them. You only conference with them. You don't go to other physicians, do you?
No, I do. Yeah. I also sometimes bring up, present cases at our tumor board at the hospital, when I need help. But I first need to understand what I'm going to do myself.
Should people see their doctor and get colonoscopies once every 5 years?
So it takes 10 years for a polyp to develop. So if your colonoscopy is completely spick and span, then you should come back in 10 years.
Really?
Right. Well, actually, I think so. Right. So then let's say if you're found to have like a small polyp, so sometimes they say come back in 5 years. There are guidelines.
You're aware of all the latest drugs, all the latest treatments, right? And if I come to you and see you and I get diagnosed with whatever it is, like the colon cancer that I had, you can save my life, okay? If it's not too far gone or past my expiration date, as far as getting cured goes. So it's also a lot to do with the patient in terms of them having, the smarts to go and get checked out, right? Before it's too late, before they die.
Right. So
waiting until 50 for colon cancer, exams is ridiculous. They should go there, and get checked out immediately too, because it could run in their family. No, just like getting checked out for anything else.
If you are like a regular person, getting a colonoscopy at age 50 is very reasonable. So probably not necessary before age 50.
So if I had gone in at the age of 50 and had a colon cancer checkup, they could have saved my life and not have this polyp grow to the point where it was a grapefruit.
Yes. So there are some colon cancers that do not arise from polyps too. Okay, so
really?
Yeah, so it's not 100%. Yeah, so and colonoscopy does not detect all cancers. Okay,
Really?
so colonoscopy detects 90% of cancers, but not 100. So in medicine, there's no such thing as 100%. So medicine is not an exact science.
But if I had gone into, ready? Okay. Dr. Max Kreditor, you're a credit to the human race and to everyone's life, as far as I'm concerned, who you've saved. And there's many more. How many people have you saved so far?
Thank you, Barry. I am blushing at this question. No, not a million. Every year I save one person.
And that's
Yeah. So to me, saving a person it means
a very important thing.
you find something that wouldn't have been found except like if it weren't for me.
How do people contact you?
Some doctors refer patients to me. They find me on the internet. Other patients refer patients to me, their friends, families, etc.
Dr. Max Kreditor, Kreditor, right? At 380 2nd Avenue, 10th floor. And how do they reach you in terms of phone numbers or email?
212-448-9555. And they can also visit our website, creditoroncology.com.
And I got to give you credit for saving my life and everyone else's out there, or anyone else who will be coming to you, who's out there now and getting their life saved by Max Kreditor.
Thanks so much.
Dr. Maxim Kreditor, you're the maximum in terms of, one more time. Okay. Dr. Maxim Kreditor, you're the maximum in healthcare, in treating people and curing people, especially when it comes to cancer, which used to be a bad word. Now it's not a bad word. People do accept the fact they might have it and want to hear more programs like this and see people like you, helping them get past it or get cured by it. So because of your work in cancer care, you've gotten awards, including the Patients Care Award. Tell me about that.
So Barry, I didn't win that award.
It says you won the award.
That award you have to pay for, so I didn't pay for it. So I doubt very much I won it.
Well, I'm going to give you that award anyway.
I appreciate it. Thank you so much.
And, God has given you the best award in the world of saving lives for people like me.
Thanks so much. I appreciate it.
By the way, you know something, Dr. Kreditor? You're a credit to the human race.
Okay, thanks.
And to the world.
Barry,
Thank you for saving lives.
appreciate your kind words. You're a good man.
God bless you. A gift from God.
All right.